Hi, class, and welcome to Chapter 12, Cancer Biology. So if you've taken a look at your book, you've recognized that this is a little bit of a complicated chapter with a lot of words, and you just don't need to know it to that depth at this point in your education. I mean, maybe someday, you may work as an advanced practice nurse in cancer, and you certainly will have a lot to learn, but this is just kind of an overview and just to kind of get you a little familiar, a little bit of a foundation. So again, use the chapter as a reference, but use this PowerPoint more as a guide as far as what is expected for you to know at this point. Okay, let's start here with the very first slide. We're talking about a neoplasm, which really is another word for cancer. And just as a little review before I get started, if we kind of think about when we think about when back in chapter, what was it? Chapter 1, when we talked about cells and cells adapt. We talked about the different types of adaptation, how cells adapt, and then we said cells either adapt and then they kind of recover, or cells die. And then I told you we had that little chart, and the cells adapt, the cells die, and then I said there's like a third one over here that chapter really wasn't talking about. The other thing that cells could do is just ignore the rules of adaptation. They don't follow any of those rules. They don't adapt and they don't die. And what happens then is they turn into cancer. So when a cell is injured or has a default mechanism for replication, okay, and cell proliferation, so cell proliferation is replication, or differentiation, right? Differentiation means when a cell differentiates, it's a less specialized cell and it becomes more specialized. So if you don't know these words, proliferation and differentiation, please go back and learn those. So it's when the proliferation or the differentiation goes wrong, then neoplasms or cancers can develop. These are also called cancers or tumors. Tumors are referred to as neoplasm, which means new growth. Just because somebody has a tumor, it doesn't mean that it's cancer. A tumor has to be determined whether it's malignant or cancerous, or if it's non-cancerous and benign, and we'll talk about the difference in those tumors. Oncology is the study of tumors and their treatment. So the cancer cell, just as a little review, kind of what happens is it's just a bad outcome of a mutation. Normal cells, when we talk about cells that aren't cancer cells, they find a home, they stay there, they grow old, and they die of apoptosis. That's just the normal lifespan of a cell. Cells detect environmental clues for changing. There's different signals for cells for them to adapt or to die. And genes tell the cells what to become, or there's genes that say they tell the cells how to differentiate. Again, they tell these less specialized cells, like a stem cell, what to become. You're going to become a more specialized cell. You're going to differentiate into a skin cell, into a muscle cell, into a cardiac cell. Old or unnecessary cells obey apoptosis. So if a cell is old or if a cell is not necessary, apoptosis occurs, okay? But cancer cells don't obey apoptosis. They don't die, they replicate. Cancer cells de-differentiate themselves, okay? They de-differentiate and become a stem cell. So they go backwards from a specific cell to a more generalized cell. And they de-differentiate in all the stages of mitosis. So they end up not looking like themselves. Cancer cells de-differentiate, they go backwards and become a stem cell to become whatever they want to turn themselves into later, okay? And we see this under a microscope. We look at cells under a microscope and we expect that the cells of the skin is going to look this way, and under a microscope we see that they don't. They look like something completely different. So they de-differentiated and basically turn themselves into whatever it is that they wanted to turn themselves into, and they don't look like themselves. Alterations in cell growth and replication. Again, neoplasm, which is new growth, lacks normal controls of regulation. So when proliferation and differentiation goes wrong, a neoplasm can develop. That's how they turn into that. Can originate in one organ or cell or tissue. Prostate is the organ that's most common in men that we see neoplasm or cancer. Breast is the most common organ in women that we see cancer. And lung is the leading cause of death in men and women. It's not the most common cause of cancer in men and women, but it's the most common cause of death, cancer death in men and women. It can also spread from one site to the other. It can be a primary neoplasm or a primary cancer that originated in one organ and spread itself to another organ, and then that would be considered more of a secondary cancer if it goes to another organ. Carcinogenesis, remember, cancer in the beginning is genesis. Cancer development and de-differentiation occurs, and there's phases that I want to go over. So what are the phases or steps of carcinogenesis? 1, 2, 3, 4. First is initiation. You see initiation, the carcinogen occurs like an introduction to an agent. So we talked about carcinogens, and I think we did. If not, we're going to. Yeah, we did in chapter 1. Something like cigarette smoke, or maybe some genes, like a certain type of a gene, something that's genetic. Maybe a certain type of food, or a drug, or alcohol, or something in the environment, pollution. Okay, so the carcinogen initiates an introduction to the agent. Then it moves into promotion. Promotion is the second stage. Initiation of uncontrolled growth. Okay, so now there's a genetic change and the cell has this uncontrolled growth, and that's something to always remember about cancer. These cells just, it grows fast. If somebody has a tumor and it's not changing size, or a spot and it's not changing and increasing in size, it's very likely that it's not cancer. So promotion, and it has the cell multiplication or initiation of uncontrolled growth because there's no apoptosis going on. And there's a genetic defect most likely in the DNA, and that's what causes the cell replication or multiplication. Next, it goes into the third stage, which is transformation, and it actually changes. You see how they multiply, then it transforms. The DNA in the nucleus just does whatever it wants, and now it transforms into a malignant cell. And then the last stage is the progression, and it goes into progression, which is a permanent malignant change. This could take years and years for this process to go on, or it could be very quick. Some causes could be, like we said, we talk about genes. When we talk about genes, hereditary, genetic, somebody's just predisposed, they have the genes. Oncogenes are really kind of called cancer, onco meaning cancer genes. And they are genes that say to the cell, multiply, multiply. And all cancers are thought to be a result from mutated DNA, like I said, inside the nucleus here. And that's why they change like that. We talked about carcinogens, and they're just cancer-causing substances, chemicals, radiation, even biologic as far as age, hormones, weight gain, just multiple things like that. So causes, we have genes, hereditary, and the second thing is environment. So those pretty much encompass the causes right there. Tumor classification and nomenclature. Classification starts with knowing the tissue and organ of origin, the extent of distribution to other sites, and the microscopic appearance. May include the genetic changes. Okay, so we're going to talk a little bit more about these three things coming up. There's two types of tumors, like I said, benign and malignant. They both replicate. Sometimes most malignant cells are cancer cells. Benign cells are basically benign. They generally don't cause any problems or any symptoms. However, if you think about a tumor in somebody's brain, even if somebody has a benign tumor in their brain, they certainly can have neurological symptoms because they have a space-occupying lesion in their brain, so it still would have to be something removed. But we do need to talk about the difference between the two right there. Let's talk about naming cancers, which is what nomenclature is. And they're named according to the tissue from which they arise. And you can kind of see the prefix in front of some of them. In front of the word is, again, the prefix. The first part of the word is from the tissue that they come from. The second part is the second part of the word is either a benign word or a malignant word. So they're named according to the tissue which they arise and include the suffix sarcoma or carcinoma if they're malignant, and just oma if they are benign. So oma, benign, like melanoma, lipoma, lymphoma. So omas generally are benign, where a malignant has more of the carcinoma in it. Adenocarcinoma would be something like that. So those that's kind of some helpful hints in regard to naming the prefix, where it's from, and either ending in oma, which again is benign, carcinoma, or sarcoma, which is malignant. Let's talk about the difference between a benign cancer and a malignant cancer or tumor. A benign tumor grows slowly. Anything that has to do with cancer is going to grow rapidly. So sometimes we just take CAT scans of somebody's lungs, for example. We see a spot or a little nodule on the lung. Well, we can't really go cut open and take a look at it, right? We're not going to just immediately biopsy. We're going to look at it. And maybe 3 months later, depending on the size, we take another CAT scan of their chest. And if that little nodule has gotten bigger, that becomes very concerning, because we know that cancer grows rapidly. If it's something benign, it's not going to grow, and we notice that. And when we compare CAT scans, it's a well-defined capsule. Okay, it's not invasive. It's just this tumor that has this nice capsule around it, and it's inclusive. Whereas malignant, it's not encapsulated. So it has these broken edges. You can see this right here. It's not capsulated here. This is an opening which is going to this blood vessel. This is opening which is going to this lymph node right here. This is an opening which is going to the skin right here. Well differentiated. For a benign tumor, you look at under the microscope and like, yeah, that looks like a cell. That looks like a fat cell. Or poorly differentiated, look under a microscope and go, what in the heck is that? We just don't know what that is. Low mitotic index, high mitotic index in regard to mitosis. Benign tumors do not metastasize. They don't grow break the basement membrane, invade, and spread to the lymph system or the blood system. But malignant tumors can spread distantly or metastasize to another organ. So generally these cancers, they just grow and grow and grow because they multiply, and their little arms and fingers invade a vessel, and then the cancer cells get into the vessel and it travels around to another organ. We call that metastasis. Same with the lymph node. It finds a little lymph node because there's blood and nutrients in these things, and it's dying to just suck up all the blood and nutrients and sugar that it can. This right here is just kind of like a picture. When we talk about initiation, we have a normal cell, and then there's some initiation, and the cells change and goes into like a mild dysplasia, into more of a severe, a little bit longer. Now time has lapsed, and we have a moderate dysplasia. More time has lapsed, so dysplasia can have different stages. This is a severe dysplasia, and then it turns into a tumor cell. So we can see here normal squamous epithelium, and now you can see that there's some dysplasia, and you see how the cells are changing, and they just moderate, severe, but nothing's broken through the basement membrane here. And then the carcinoma in situ, which now it's going to start to even get deeper. Okay, so it's starting to move deeper, breaking into the basement membrane. And then once the basement membrane breaks in the cell, then the cancer starts to invade. starts to invade an adjacent organ right there. What's the difference between invasion and metastasis? So invasion is a local spread of malignant neoplasm by infiltration or destruction of an adjacent tissue. So here's the primary site. It's breaking through the basement membrane of the cell and invading an adjacent tissue. Metastasis is a transfer of cells in one malignant tumor from an organ or part to another, not directly connected to it. Okay, so now we have these cells. Now they get put, like I said, into the blood or into the lymph, and they spread around, and now they are invading another tissue that's not adjacent, right directly next to it. Invasion occurs through the infiltration or destruction of the basement membrane of the epithelium, and metastasis occurs through the circulatory or lymph system. A type of local spreading, since it only invades nearby tissues, and this metastasis leads to the invasion of tissues in distinct locations to the malignant tumor. Invasion is obviously less threatening, but it certainly can turn into metastasis. And metastasis is life-threatening. That's an indication that there's been significant spread. So who gets cancer? Second leading cause of death overall for patients who are 60 and over, only second to coronary artery disease. Overall mortality rate is 50%. Some always kill. Some cancers will always kill somebody. Lung cancer will progress. Pancreatic cancer. Some don't. They just become a nuisance, and patients just have to have treatment for them. Epithelial cancers outnumber all other cancers 6-1 and are curable. Least common cancers usually lead to the highest fatalities, like pancreatic cancer, which is not a common cancer, but it tends to lead to cancer fatalities. Why are cancers so challenging to deal with? Causes, behaviors, treatments vary greatly. There's so many things involved when we're talking about cancers in regard to what organ it is, how old the person is, genetics, just so many different types of variables. And also treatments vary greatly. Some treatments can be excellent for one type of cancer and not excellent for a different type of cancer. The top 10 causes of death in the USA, and this is basically, like I said, 60 and over, so it is important to understand that, whether somebody's black, white, man, woman. Heart disease is the #1 killer in people in America over 60 years old. Cancer is #2, okay? And it is very high on the list for suffering and death, cancer. So heart disease #1, cancer is #2. Interestingly, COPD and chronic lung disease is number. Actually, I think they have these two flip-flop. Looks like they have stroke being #3 and then COPD being #4. But these are the top 4 all the time. And like I said, these two sometimes switch. Estimated cancer deaths by site in the United States. So lung cancer, we're talking about the leading cause of cancer death in men and women. Not the most common cancer, but the most common cancer death, lung cancer, hands down. These are other cancers in regard to cancer deaths: breast, prostate, pancreatic, colon. Okay, all added together equal the same cancer death rate as lung cancer. Why is cancer so hard to cure? Well, again, just a lot of variables. About 70, humans have about 37 trillion cells, 200 types. Just these different types of cells and the different parts of the cells and molecular mechanisms that go on with DNA and cancer. So this is why it's just very complicated. Okay, so 3 variables in frequency and significance of cancer. So number 1, the site of development. So what is significant when we talk about cancer in regard to frequency and significance? What are some things that matter in regard to that? Number 1 is the site of development. Did it develop in the lung? Is it in the colon? Is it in the breast? Is it in the prostate? So that does matter. What about the gender? Is it a cancer that's common in women or not common in women, vice versa? And what about age? Obviously, the older we get, there's more genetic damage, more DNA is damaged. Okay, so those 3 things are variables in frequency and the significance of cancer. And this is just a little chart that kind of shows you this. So number 1 for men, the most common cancer, the most frequent cancer in men is prostate. The most common cancer, the most frequent cancer in women is breast cancer. Now look at number 2, lung for both of them. So it depends on the organ, the gender, and certainly, like I said, the age. Look at number 3, bowel for both of them. Okay, so lung cancer and bowel, those are frequent cancers, whether they're man or a woman. Prostate is a frequent cancer for a man. Obviously, as he gets older, it becomes more frequent. Breast cancer, the most common cancer for a woman. 5-year survival rates, just if a cancer is caught early. So this is old data, but it's still very, very true. For stage 1 of the most common cancers, this is early. Stage 1 is early. I'm not talking about, you know, getting cancer, catching cancer at stage 3 or 4. When caught early, breast cancer is 100%. The survival rate is 100% if it's caught early. That's why we do breast screening. That's why breast screening becomes very important. Prostate cancer, if it's caught in stage 1, 100% survival rate. That's why we screen men over 50 years old for prostate cancer, because they're the most common person in age, gender and age, who's going to get it in that organ. Colon and rectal cancer, if we catch it in stage 1, 88% survival rate. That's why it's recommended that patients over 50 get colonoscopies. When they're found to have a polyp or something that could be precancerous, they have colonoscopies more frequently than if they don't have something that would be an indication of precancer. Melanoma, if it's caused and found, almost 100% survival rate if it's caught early. Skin screenings are recommended every year for adults. The last one here, the toughest one to survive, and is the reason why it has the highest death rate of all cancers, is even when it's caught early on, only maybe about a 50-55% chance of a survival rate. So this is very low. Lung cancer is very low in survival rate. And generally, we don't see it at stage 1. It often isn't even become evident until it's later in stages. And most people who have stage 1 and they're little teeny nodules, they're only found incidentally when they have a CAT scan, because there really is no screening tools that we do for just anybody for cancer. Now, there are some screening recommendations for smokers if they're current smokers and they're of a certain age, I think 70, and they've smoked 30 years, or they have quit like within the last 15 years. Getting a CAT scan every year is a screening tool, can be a screening tool, again, depending on what the insurances are, but it's not a screening tool like we do have with the other ones. So common sites of metastasis, we see when remember, the tumor or cancer originates in one organ and then spreads to different organs. We call that metastasis. So the breast, and breast cancer often metastasizes to the lymph nodes, the lung, the liver, the bone, the brain, colorectal, liver, lung, the lining in the belly, lung, liver, brain, bone, ovarian, belly, liver, lung, prostate, bone, testicular, lungs, liver, bone. Okay, they are filters in the body. They all have very high blood flow. There's just a lot of vascularity and a lot of blood flow going to these three things, and everything travels through these organs. So lungs, liver, and bone, you can see, are three common areas or three common sites for metastasis, regardless of where the cancer originates, what we call primary cancer, where that originates. You see, we really don't have nerve cancer or heart cancer or skeletal muscle cancer. And these are organs that have cells that do not replicate. So we don't see heart cancer because the cells are just different than these types of organs that we see cancer in. These types have cells that replicate a lot more frequently. So talked a little bit about cancer screening, and this is probably just a review. Breast cancer, we do mammograms and self-breast exam, pap smears for cervical cancer, endometrial biopsy. If we see that the endometrium of a woman is measuring a little thicker in a ultrasound, we can certainly get a biopsy. A PSA, a digital rectal exam, is done in men to screen for prostate, and of course, colonoscopy for colon and rectal cancer. 1 in 3 cancer deaths should be prevented with early detection, could be prevented with early detection. So screening is important. Let's talk about clinical manifestations, and these are things that you learned in nursing school. So CAUTION, change in bowel or bladder habits. This can be indicative of colon cancer, bladder cancer, kidney cancer, prostate cancer. A sore that doesn't heal. Somebody has decreased immunity, and maybe they have a sore that just isn't healing, because with cancer they're going to have a decreased immunity because the white blood cells are now depleted, the red blood cells are depleted, platelets or cells, their blood cells all get depleted, so they become more immunosuppressed. They have a sore, and they have a sore somewhere on their hand or on their body, and it just isn't healing. Unusual bleeding or discharge, maybe like in the breast, the vagina. Thickening or lump in the breast or elsewhere, meaning that you feel a lump, you feel a tumor in the testicles, in the lump, something like that. So that's obviously something that we need to have a workup. Indigestion or difficulty swallowing can be tumors in the throat, in the glands, in the neck area. Obvious changes of a wart or mole. Generally now we have hyperplasia, which can lead into any type of skin cancer, especially if it changes. That shows that there is proliferation and replication, and it's just changing and changing. A nagging cough or hoarseness, which could be lung cancer, throat cancer, things like that. So there's other things like some main symptoms: unintentional weight loss. So cancer just likes to eat up everything in the body. So these people are losing weight, they don't know why. Night sweats is never a good sign. Somebody who's sweating all night generally is an indication of a couple things. One, they're menopausal, so it could be a woman over 50. And then the other things are tuberculosis and cancer. So night sweats are something to be concerned about. But like I said, women 50 and older going through menopause would be something we would expect. Some other clinical manifestations: paraneoplastic syndrome. These are symptoms that occur, and these symptoms can be a list of symptoms as long as your arm, and they're caused by biologic substances released from the tumor, from the tumor, hormones, or by an immune response triggered by the tumor. Okay, so the pathogenesis of paraneoplastic syndrome: tumor stimulation of antibody production of cytokines, production of enzymes or fetal protein. So all these like hormones get produced because of because of the cancer. Metabolism of steroids by the tumor production of protein hormones, and multiple other things. So they have these symptoms, and they're caused by these substances that the tumor releases. The tumor releases these hormones and these substances. It can cause GI symptoms. It can cause respiratory symptoms. It can cause skin symptoms, symptoms of the eye, just just all kind of different symptoms. So again, it could be its own lecture really talking about this. Just wanted you to be familiar with what it means, what it is. Some more complications, anemia. Like I said, keep in mind that red blood cells decrease because red blood cell production is affected. Bone density loss, especially when cancer starts moving into the bone and there's no room for the bone because the cancer is taking over, so the bone becomes hollow and dense or denseless. This cancer cells multiply, they get more and more and more, and they just get crowded in there and they crowd up the bone marrow, and that also contributes to anemia. Cachexia, which is a wasting syndrome, they have a loss of appetite, a loss of muscle fat, that weight loss. Cancer needs energy. It's eating up all the nutrients and the sugar in the body, and that's why somebody has weight loss and they feel lousy, so they don't want to eat. Cardiac, pulmonary damage can occur, so any really body system can have symptoms. Fatigue, GI issues as far as nausea, some vomiting if the gut is affected, hair loss and skin, infection because of a decreased immunity. It can affect another body system, the reproductive system. Leukopenia, the white cells decrease, thrombocytopenia, platelets decrease, and again, keep in mind that the cancer cells multiply, and so that bone marrow gets crowded out, right? So the cancer cells growing in here and it crowds out the bone marrow. So they have pancytopenia, meaning a decreased red blood cells, decreased white blood cells, decreased platelets, pancytopenia. Lymphedema, the immune system's trying to work overtime to kill the cancer. And pain, especially severe in something like bone cancer, but this bone pain, cancer pain, is very highly responsive to morphine, so they generally are on narcotics like morphine. So diagnosis. So biopsies can be helpful and they can be done through a needle aspiration. We can do endoscopy and do biopsies through an endoscopy. I could put bronchoscopy here. We could do biopsies through a bronchoscopy, a laparoscopy, or an excision, just cutting. So just getting a needle in the area that we want and grabbing some type of aspiration through a needle or a biopsy, a piece of tissue. Tumor markers, they're antigens on the surface of tumor cells, and they're found higher than normal. These are some of them right here. In blood, in urine, and in the body tissue of patients who have cancer. So they have tumor markers in their body fluids that are increased. So they are used for screening, okay? They're used for diagnosing, used for monitoring the progression of somebody's cancer, treatment, establishing if somebody is in remission. Your book talks a little bit about the different tumor markers. You certainly do not need to memorize these. Just there's different markers that can be tested in the blood and can give us an indication of what's going on with the cancer as far as the amount and things like that. Then some miscellaneous procedures, certainly x-rays, CAT scans, endoscopies, sonograms, MRIs, PET scans. So, like when you get CAT scans and you get MRIs, they look at anatomy, of the organs. And a PET scan is a little bit different. And a PET scan looks at activity, not necessarily anatomy. So we get a CAT scan with a PET scan. Positive emission, what is it? I forget. And what they do is they put an IV in somebody and put sugar water in the IV, and the sugar travels around. And whenever there's an organ that has cancer, has malignancy in it, that organ sucks up that sugar and it is lights up. Okay, there's a tracker in there and it lights up and those organs light up, and that's how we can see if there's activity, is what a PET scan measures. Malignant cancer cells are classified, so we're going to talk about Continuing here with diagnosis, we're going to talk about classifying. So malignant cancer cells are classified based on the degree of differentiation or grading and the extent of the disease or staging. So we're going to talk about grading and staging. Grading on a continuum, we'll talk about grading, and that's a pathologist's job to take a look at the tissue and grade the tissue. And staging, tumors, nodules, metastasis, TNM staging, and it evaluates for T, tumor size, N, are the nodes involved, right? Because that gives us an indication of progress. Is it progressing? Is it spreading? Staging, tumors, nodules, metastasis gives us an indication of spread. How big is the tumor? Are there any nodes that are involved? Because if they are, that's spreading. Is it metastasizing? If it is, that's spreading. So here, classification TNM, the tumor size, the node number, the metastasis, evaluates the tumor size, nodal involvement, and metastasis. Now we can put a line here because grading is different. So staging is number one, grading is different. And again, it's according to histology. And we grade 1, 2, 3, and 4 as the stage increases. The tumor is less differentiated, right? So we're looking at the degree of differentiation here. As this number increases, the tumor is less differentiated. A grade 1, we would look at and go, yeah, that looks like a skin cell. Yeah, that looks like a endometrium cell. Whereas it is a grade of 4, it's less differentiated. It looks something completely foreign. So this is just kind of a little picture of that. Staging, keep in mind, I'm going to ask you what staging is, and you're going to tell me that it's progression or spread. That's what staging tells us about spread. Grading, cell differentiation, and rate of growth. We need to look under a microscope. So we have grade 1, grade 2, grade 3, grade 4. If it's low grade, it's well differentiated. If it's high grade, number 4, it's undifferentiated, okay? So this is a low grade. Grade 1 is low, meaning it's highly differentiated, well differentiated. G1, well differentiated. Number 2 is more of what we call like an intermediate, which would be moderately differentiated. And a stage 3 we call high. That's a high grade. A stage G3, this is going to be poorly differentiated, meaning this is hard to see in the microscope. What is this? This certainly does not look like this, does it? Okay, so the last one, grade 4 right here, is the highest grade, and it's just unidentifiable. These are just, you just look under a microscope and I can't make any reason what they are. Grade 4 is the highest. This is just another kind of a way to talk about the TNM, just kind of explain it a little bit as far as, I think I have another slide on here too. The TNM as far as the tumor involvement, limited. T1 is limited to the mucosa. I can kind of show you the picture here. T1. So right here, this T in situ right here, TIS, is the beginning. It starts going into the tissue. We talked a little bit about that. This is easy to treat. Get a knife, scoop it right out, okay? Then it progresses. It starts in situ, then it progresses to T1. And T1, you can see, is limited to the mucosa. Okay, T2. Now T2 is right here. Is it extended? So it's extended, but it's not through the fat. Okay, it might be up into the fat. Extension, but not through just the fat, basically, is the way I remember it. T3, now we have invasion of this fat. You see how the third one, it goes into deeper into the fat. And then stage 4, invasion of adjacent structures. T4, which is the 4th stage, you see here's an adjacent organ right here. This is the stomach wall, and now it has broken the membrane and invaded this tissue right here. Okay, so you should know what T in situ is, T1, 2, 3, and 4. So somebody could be T1, So we know that this is what it looks like. It's just right here and limited to the mucosa with an N0, meaning that there's no node involvement, with an M0, no metastasis. A T1, NO, MO is the best one that you can get, right? That's the least level of involvement. A T4, we have invasion of adjacent structures. An N3, distant nodes. Now you can see some nodes involved, more nodes involved, distant nodes involved. M1, distant metastasis. A T4, N3, M1 would obviously be the worst. So we look at those three things and really should kind of understand what the T and M is. That's pretty basic. Whoops, sorry. Okay. Last couple slides, just basic. So what about treatment for cancer? Again, your book gets into it a little bit more, but there's three main treatments for cancer. One, being chemotherapy, which can be oral chemotherapy. It could be IV chemotherapy, like this one right here. Chemotherapy is chemical therapy that kills rapidly growing cells. And we know that's what cancer is. It's rapidly growing. It's just proliferating and proliferating. And cancer targets these fast growing cells. But keep in mind that there are cells in our body that are fast growing as well. And the chemo can't discern between it. So it does kill cancer cells. But stomach cells, they rapidly grow. So that's why the chemo can kill stomach cells and they get nauseous and vomit it. Blood cells, they are fast or rapidly growing cells. They become anemic because chemo will kill those cells. Skin cells and hair cells are also fast growing, so they have skin issues. They lose their hair. So there are those types of real significant side effects with chemo. Radiation, they can either be like pellets. Radiation pellets are commonly used in prostate cancer. They put these little radiation pellets in the man's prostate, or they can get radiation through a machine. And the radiation kills cells by damaging the DNA. Okay, it kills DNA. And when the DNA inside the cell is killed, the cell is going to be killed. Okay. The third is going to be surgery, and surgery has the highest cure rate, okay? The reason why it has the highest cure rate is because it's done only in early stages. Once this cancer spreads and starts spreading to other organs, surgery is not an option anymore. But if there's a cancer in situ and it's just sitting right there in the little membrane and you just go in and scoop-de-doo it out, surgery can be, like I said, has the highest cure rate. Goals are curative. We want to eradicate the disease if possible. Palliative, treat symptoms, treat comfort. Or prophylactic, we want to prevent the disease. And again, that's why we do screenings. Prognosis, remission is a period when the cancer has responded to treatment and is under control. Okay? And that's really it. This is kind of what I want you to know about cancer at this point. So thank you.